Okay, this is another lecture. The title is Postmenopausal Bleeding, Diagnosis and Management, and this lecture is part of the DAROGA YouTube videos, open access, free of charge, mainly focusing at senior medical students and junior medical doctors working in obstetrics and gynecology. Part 1, we will discuss first the definition of menopause, what is the underlying mechanism why women stop to cease their menses at a certain age, what are causes of postmenopausal bleeding, what is a differential diagnosis, and what can we tell about screening for endometrial cancer. First, what is the definition of menopause? Cessation of the menses, cessation of the menstrual periods. This is the last menstrual period took place because of what precisely? It's always a retrospective diagnosis 12 months behind the fact, and unless we are dealing with a so-called iatrogenic cause, such as an operation like removing of the uterus totally, bilateral salpingo ovarectomy, removal of both tubes and ovaries, sometimes due to radiotherapy and chemotherapy, of course, mainly to deal with cancer. So the history means there is no more bleeding per vaginum for more than 1 year. That's the definition. Of course, before the last menstrual period takes place, women most often will have so-called perimenopausal symptoms, and typically are hot flushes, or also called hot flashes in the United States, night sweats, mood swings, joints, aches and pains, and the menstrual cycle is quite often irregular. Why is that so? The ovary finds it more difficult to produce an egg on a regular basis, so some cycles are anovulatory, which results in the subsequent menstrual period being heavy and quite often painless. So it's almost typical for perimenopausal women. Some women might approach you as a GP or a gynecologist and ask you, doctor, would you check my hormones? If the above complex of symptoms occurs, checking hormones is not very useful. However, for women, some women, it has a magical appeal, so if you decline to check hormones, be sensitive about it. If you would like to check a hormone, only one hormone is useful, and that's only FSH. Why is that so? So if there's no typical symptoms, and a lady is maybe 43, 44 years of age, checking one FSH level at day 3 of her menstrual cycle, and if that FSH would be increased above the normal range, that would point at perimenopause. Because FSH is directly linked to the production of estradiol in the granulosa cells, the cells which surround the dominant follicle, as you might know, and there is a direct feedback loop to FSH. Checking FSH is not useful. We only want to know the LH peak in case of an IVF cycle or in case of fertility treatment. Let's go now to the underlying mechanism. The underlying mechanism of the cessation of menses is depletion of ovarian germ cells. There is no more follicles, primordial follicles, to be stimulated. Found is a very intriguing chart. On the x-axis we see the lifespan. Here the lifespan in utero. This is the time where we see the arrow where the baby girl is being born, and we see here the years on the x-axis, up to 50 plus. On the y-axis we see the numbers of germ cells present in the ovary, expressed in millions. In utero, the number of follicles in total is close to 7 million when you're 4 months in utero, and from then on the decline starts to happen. When the baby is born, you still have 1.2, 1.3 million germ cells in the ovaries. And from then on, it drops. And here, at the age of 50, this is when usually the menopause happens. There's no more follicles available. This process we are unable to influence. So even if you would give a girl the contraceptive pill to suppress ovulation, this process, there's no way we can shift this curve maybe to the right. A question. At what age takes the menopause usually place in Australia? What is the median age? 50 to 51 years of age. Most women will arrive in the menopause, will have the last menstrual period between 45 and 55 years of age. If a woman would have premature ovarian insufficiency, that is per definition if she has no more menses due to ovarian insufficiency when she is younger than 40. At this stage today, we prefer to speak of primary ovarian insufficiency rather than primary ovarian failure. That might be misunderstood and be regarded as a qualification by a woman. What is now roughly the incidence of postmenopausal bleeding, the topic of today, at the age if a woman is in her 50s, in the early menopause? That is roughly 6 in 1,000. So as a GP, you will see that a few times every year. The incidence of postmenopausal bleeding will decrease with age. What are causes of postmenopausal bleeding? Of course, as gynecologists, we have this statement: postmenopausal bleeding is endometrial cancer until proven otherwise. But let's think outside the infamous box. I would feel, don't learn this by heart, but apply common sense. First, we can think about a number of non-gynecological causes, such as a carincula of the urethra, or bleeding coming from the bladder, hematuria. Here we see the carincula of the urethra, a little protrusion of the epithelium, a red spot here at the mouth, at the opening of the urethra. Most women will know whether a bleeding comes from the genital tract or not, but especially elder women, women in nursing homes, might not be able to differentiate and tell us where it's coming from. Other tract would be the bowel, rectum and anal bleeding, especially in nursing home women. Here, for instance, we see external hemorrhoids depicted nicely. Here are internal hemorrhoids. They could result in bleeding found in the underwear, and it's not always easy to differentiate. So it's good to think about those options as well, even when you are preparing for a gynecological exam or career. Gynecological causes, I would think it makes sense to follow the anatomy from proximal to distal, from low to high. And here are they listed. A bleeding from below could point at vulvar problems, vagina, cervical, uterine, ovarian, or even, in very rare cases, cancer of the uterine or the fallopian tubes. So from the gynecological point of view, we could discriminate between non-uterine causes and uterine causes. Non-uterine causes of postmenopausal bleeding, well, vulva. Here's an example of a lady where you see the left labium changed by vulvar cancer. Here is one tumor and here's another in the left vulva region. Of course, most women would have noticed a lump in the vulva region, which eventually, if not detected early, will start ulcerating and bleeding. Vagina, the same. The most common condition, however, in the menopause would be atrophy of the vagina. The vaginal epithelium, the non-keratinizing squamous cell epithelium, is thin and the underlying stroma becomes more visible. Here's a picture of the vagina where you see little point bleeding, which is typical for atrophic bleeding. When you would perform even a gentle speculum examination, one could provoke slight bleeding. Some women who have a pessary to deal with a uterovaginal prolapse could have decubitus, a defect in the vagina or even ulceration due to the prolapse itself or the pessary. Cervical cancer could result in postmenopausal bleeding. Very rare, the ovary could produce an estrogen secreting, has an estrogen producing tumor, a granulosa cell tumor, but it's very rare. But it's in the back of your mind when you're dealing with postmenopausal bleeding. Now let's go on the focus point of today is uterine causes. The vast majority of bleeding from the uterus postmenopausal comes from atrophy as well. That means the endometrium is very thin and quite vulnerable and prone to bleed. The other part of the coin would be hypertrophy or hyperplasia of the endometrium, where the endometrium is thickened and lush. Quite common are endometrial polyps, submucous fibroids. Postmenopausal, you do not expect the fibroids to grow. To the contrary, they should be reduced in size or shrink. And now the big ticket item of today is endometrial cancer. This is our primary focus point, and that needs to be ruled out in principle in a woman who presents with postmenopausal bleeding. Let me ask you a question. What is the most likely presenting complaint or symptom of women with endometrial cancer in a postmenopause? Unsurprisingly, 90 to 95% of the women will present with a vaginal bleeding or blood-stained vaginal discharge as the only presenting complaint. And that's good, it's important, because if the woman reports this postmenopausal bleeding to her doctor, and the doctor does appropriate assessment, we can detect endometrial cancer in a very early stage, where a simple operation, a bilateral sapingo-oophorectomy and total abdominal hysterectomy, even performed laparoscopically, can cure her completely. So, postmenopausal bleeding has to be taken seriously. When endometrium cancer is detected in an early stage, an operation will be curative. I have here a specimen. The picture was provided by Professor Martin Euler, and we see here a cross-section. The uterus is opened in front, uterus here, and this is the cervix, this is the myometrium, and this is the uterine cancer. And the uterine cancer, here on the other side of the specimen, the uterine cancer has not invaded the myometrium at all. Per definition, this is stage 1A endometrial cancer. Over here we see the fallopian tube and the ovary and tube on the other side. So this is a specimen where the operation was sufficient. There was no spread in lymph nodes or outside the endometrium. Of course, a very popular question to ask in an exam is, what are risk factors for an endometrial cancer? I would wholeheartedly recommend you not to learn this by heart or just so-called rote learning, but apply common sense. The most common denominator of women who have endometrial cancer is estrogen. If you remember, estrogen, either administered or given by us, by doctors, iatrogenic, or endogenous, produced by the woman, by her body, without interference of a doctor. The risk factors are listed here, and on the right hand side you will see the relative risk of a woman who has this particular risk factor to develop endometrial cancer. It's a whole list. Increasing age, 75% of women are postmenopausal, with a peak in the late 60s. Relative risk, 5.2. Obesity, women produce excess of estrogens in their peripheral fat, relative risk between 3 to 10. Polycystic ovarian syndrome women who quite often have obesity as well, quite often are anovulatory, relative risk is 5.2. Unopposed estrogen exposure, relative risk 2 to 14. By the way, women with the uterus should not be prescribed estrogen replacement therapy only, which is obvious from the next line, where it's clear that if women are using progesterone as well, that it results in reduced risk. Diabetes, type 1 and type 2, nulliparity, never had a child born, late menopause, and another one is tamoxifen. Tamoxifen is given to women with breast cancer. Some women, it's a very powerful anti-estrogen and reduces the risk of recurrence for the breast cancer. However, and somewhat paradoxically, on the endometrium, it has a cancer promoting effect with a very high relative risk of 7.5. One condition which has not to do with estrogen exposure or production is the so-called hereditary non-polyposis colorectal cancer, or the Lynch syndrome. Those women have a family history of endometrial cancer and colorectal cancer, and they have a lifetime risk to develop endometrial cancer between 22 to 50%. So a very high risk indeed. Important as always, a woman with risk factors, one or more risk factors, does not have endometrial cancer, and the other way around. Risk factors just influence the pre-test probability, but they will guide us in practice what the diagnostic step to take and in what sequence and in what speed. It's good to know those risk factors for your written exam and also for your OSCE exam, but don't learn them by heart. It's sensible if you know the word estrogen, and from there you can derive most risk factors almost automatically. What are protective factors? What factors reduce the risk to develop endometrial cancer? The first one, cigarette smoking. Of course, this is an exception to the rule, and to be honest, I have never shared this with women. Multiparity, the use of combined oral contraceptive pill for more than 1 year, and the use of combined hormonal replacement therapy, so estrogen plus gestogen plus progesterone. What about screening for endometrial cancer? If we think about the Pap smear, sometimes in a postmenopausal woman or a perimenopausal woman, the Pap smear slide will show endometrial cells or glandular cells. Here we see an example of a Pap smear. Here the purple ones, those are glandular cells. And in a postmenopausal woman, that could mean those cells are shed from higher up in the genital tract, so coming from the uterus or the endocervix. So that's a warning sign. But the Pap smear itself is a screening for early stages of squamous cell carcinoma of the cervix, not for endometrial cancer. The same if we test for a human papillomavirus, especially the high-risk strains 16 and 18, they screen for cervical cancer risk, not for endometrial cancer. By the way, the median age for women developing cervical cancer is 52, so younger than the peak of endometrial cancer. So in conclusion, a routine Pap smear would not be adequate to screen for endometrial cancer. Application using transvaginal ultrasound scan or endometrial biopsy, we will discuss that a little bit later, are too expensive to screen the whole population of women after menopause. Endometrium cytology, too insensitive and not very specific. Progesterone challenge tested means you will give a woman oral progesterone for about 10 to 12 days and you find out whether she will respond with a withdrawal bleeding, whether she will shed her endometrium, which has been built up by estrogen. This test does not prove or exclude abnormal pathology of the endometrium. So in conclusion, in contrast to screening, the very successful screening for cervical cancer, there is no appropriate and cost-effective screening test for endometrial cancer. So we have to rely on women with an abnormal bleeding pattern in the perimenopause or women with postmenopausal bleeding to present to their doctor, and the doctors being knowledgeable and do a proper and quick assessment. Compare that with the cervical screening, which is a success story of the last 30 years. This concludes part 1 of the video Postmenopausal Bleeding, Diagnosis and Management. In part 2 we will discuss what are the most appropriate investigations in women who present with postmenopausal bleeding, what should be the management, and we focus as well on enzyme-like growth factor 1, which is a contributor to the development of endometrial cancer. And then I will ask a few questions to conclude. Thank you for your attention, and hopefully you will continue with part 2 of this video.